Hello, my name is Dr. Jessica Cronce. I'm an associate professor in the Department of Counseling, Psychology, and Human Services at the University of Oregon. I'm going to share with you an overview of alcohol prevention. I want to start with the question why. Why should we focus on prevention as opposed to, for example, treatment? Over 95,000 deaths per year are directly attributable to excessive alcohol use, making it the leading cause of preventable death in the United States. In total, this amounts to 2.8 million years of potential life loss, or shortening the lifespan of these individuals on average 29 years. Some of the conditions that alcohol use contributes to leading to these deaths are various cancers, such as esophageal cancer, and organ diseases such as liver disease. But these are often considered to be chronic conditions that take multiple years to develop, as opposed to more acute causes that are linked to alcohol use, such as traffic fatalities, drowning, and accidental poisoning, including poisoning on alcohol itself. That is, ingesting enough alcohol for your respiration and heart rates to slow to the point of stopping. In addition, a number of other negative physical and mental health outcomes are attributable to alcohol, such as injury, sleep disruption, which itself is linked to a host of negative physical health and mental health outcomes, alcohol use disorder, and other psychological disorders that are exacerbated by alcohol use, such as post-traumatic stress disorder. Alcohol use also contributes to depression and negative affect and mood, and relatedly is implicated in suicide attempts and completed suicides. Each year, the United States spends approximately $249 billion on alcohol-related consequences, which include lost work productivity as well as increased healthcare utilization, all of which constrain social resources. So why should we prevent alcohol use and related harm? One, to save lives. Two, to improve the quality of life of individuals. And three, to help preserve vital social resources. So when should prevention be the focus? Alcohol use varies across the lifespan. It also varies across any individual's life throughout the year, different circumstances, but we can see these very predictable patterns increasing from childhood and adolescence up through young adulthood. You can see the period from 8th to 12th grade, which is the first sort of segment of the graph, where there's this steady increase across those years. And then that increase continues from 12th grade to approximately age 21, or the minimum legal drinking age in the United States, with a steeper increase in past 30-day drinking across this age range before each of these indices plateau. So looking at lifetime, annual, past 30-day drinking, it's all very similar patterns. This increasing pattern is also seen in daily drinking and indices of heavy episodic drinking, so consuming 5 or more, 10 or more, or 15 or more drinks on a single occasion over the past 2 weeks. However, the increases in these are not quite as steep for all of these indices. So you can see that up to age 21 is sort of a prime time to engage in prevention to hopefully decrease the initiation of alcohol use, as well as decrease the likelihood of heavy episodic drinking and other higher risk drinking patterns. But alcohol use has the potential to cause harm over the entire lifespan, and therefore prevention is appropriate at all points over the lifespan. So what should the focus of prevention efforts be, and where should prevention be implemented? So the most distal targets for alcohol prevention are alcohol-related harms or negative consequences. Most often we focus on the harms to the individual who consumes alcohol. From a prevention standpoint, I will note that it's important to take into account different perspectives when we talk about harms. So researchers, we might say, X, Y, and Z are harms associated with alcohol. However, from the perspective of the individual consuming alcohol, They may not see it that way. And my research centers on young adults and in particular college students. And there's good data to suggest that while I might see an alcohol-related blackout as a negative consequence to be avoided, that perspective may not be shared by all young adults. And in fact, research suggests that at least some young adults see that as an intended outcome. That is, they see it as a positive, something they were striving to happen. So when we implement prevention, it's important to realize there are these different perspectives. Additional alcohol-related harms are what we sometimes call secondary effects, or the impacts of alcohol use on individuals other than the person who was consuming alcohol. So these can include interpersonal and sexual violence, traffic injuries and fatalities to passengers in the car where the driver was intoxicated, or other drivers in other cars that are impacted by the accident. Disruption is another secondary effect, and this is a common one listed by college students, where other individuals who are drinking are coming back into a shared living situation, are noisy, may be physically ill, making a space unusable to others, those types of disruptions to their life. Property damage is another commonly cited secondary effect. All of these might be distal targets important to different stakeholders. Of course, if we're trying to prevent alcohol-related harms, we also want to reduce alcohol use directly. So there's different targets within this category. We might seek to prevent or postpone initiation of drinking, especially in prevention with younger individuals in childhood and adolescence. This might be the main goal for individuals not drinking yet to prevent drinking from occurring. However, once individuals make the choice to drink, we might shift our focus to preventing progression to higher risk drinking, or again, for younger children and adolescents in particular, including supporting returning to abstinence, even once drinking has been initiated. Abstinence is, of course, always the least risky option. However, abstinence-focused approaches don't work equally well across all age ranges, which is something that I'll come back to. So for individuals who've made the choice to drink and are of legal age to do so, in particular, we may focus more on reducing the pattern of higher risk drinking if that pattern has set in, or maintaining lower and moderate risk drinking in those individuals. In order to achieve those distal prevention targets, we might focus on more proximal prevention targets. So these are the risk and protective or resilience factors that shape alcohol use. These factors can change over the lifespan and do change over the lifespan, as well as differ across individuals and differ by group, and all of them are influenced by context. So it's important to take all of those factors into account. And all of these different things necessitate different prevention targets and strategies. So focusing most specifically on the lifespan, if we start at the first place where someone might be exposed to alcohol, it's actually in utero. The pregnant mother who consumes alcohol is exposing their child, their growing fetus, to alcohol, which may have the effect of fetal alcohol syndrome. And so prevention at this stage is focused on abstinence during pregnancy. These prevention strategies are most often implemented in medical settings, conversations between medical professionals and the pregnant mother. Childhood is sort of the next stage, and these prevention strategies are most often implemented within the context of schools. The proximal targets might be healthy parent-child relationships, building social, emotional, and cognitive skills, and reducing aggression. Especially early in childhood, reducing aggression can be an important target, as we know that this is linked to later problematic alcohol use. In adolescence, we largely keep these targets the same, however, might start including substance refusal skills, especially as adolescents make the choice to drink. So how to refuse skills, or how to refuse a drink when someone offers or might exert peer pressure. These strategies also tend to be school-based, as most children and adolescents are within a school context. In young adulthood, as individuals start going into different contexts, while there is a concentration of these strategies being applied in college, which again is my focus of research, there are many, many, many young adults not in college, and there are various ways in which to reach them, many of which also apply to those in middle to late adulthood, which I'll talk about in a minute. Within the developmental period of young adulthood, some of the proximal prevention targets might be parent-child communication around alcohol use. So even though the child may no longer be in the home, that young adult is still engaging with their parents, and parents are still influential. And so we might target prevention to the parents to help support them in communicating around alcohol use with their child. Additionally, correction of misperceived drinking norms becomes important at this age. In particular, young adults tend to think that other people are drinking more than they themselves are drinking, and often significantly more than the actual norm. And correcting this misperception, decreasing that norm, can in effect decrease that individual's drinking. Awareness of personal drinking behavior and harms is also an important proximal target, as well as skills to moderate drinking and reduce risk, so protective behavioral strategies, and then increasing motivation for change. All of these might be targeted together in an effective prevention strategy. Really important to this developmental stage are a couple different factors. So one, in the period we often think of as young adulthood, so age 18 to 25, or sometimes defined as 18 to 30, individuals cross the minimum legal drinking age. And again, you saw that increase in drinking up to age 21, and then it sort of plateaus. But the focus of prevention may be very different when talking about underage drinkers versus of-age drinkers. Additionally, there's a plateau in brain development at approximately age 25. And so the focus of prevention still needs to include focusing on those who are currently abstaining to try to prevent the initiation of drinking, because the longer you can forestall that, the less impact that will have on the developing brain. In middle to late adulthood, most of prevention is centered in employee assistance programs and medical or public health settings, such as emergency departments. And again, young adults not in college are often intervened with in these settings as well. The strategies in middle to late adulthood overlap with young adulthood, but focus more on the individual themselves as opposed to the family context. And it might focus on awareness of personal drinking and harms, skills to moderate drinking and reduce risk, as well as increasing motivation for change. So as I alluded to before, context is really important. And within developmental stages and across groups, we need to take context into account. One example of where this is salient specifically for my research is college versus non-college. So even though young adults overall are drinking more, say, than those younger than them, and it reaches this plateau during this developmental period, those in college versus not in college and multiple indices of drinking are actually drinking more. So in a lifetime, in annual and past 30 days, as well as what's referred to as heavy episodic drinking, so 5 or more drinks in a row on a single occasion, those in college are actually evidencing these types of drinking at higher rates than those not in college. However, you will see that daily and drinking 10 or more drinks in a row, actually those young adults not in college are doing so at a greater rate than those in college. So we want to take context into account when we think about which groups are at greatest risk for harms associated with alcohol use, and to think about what is it about that context that is increasing this risk for use and potential harm. So as we think about that, as we think about context and the individuals, we can think of these as two main areas of focus. So the individual, we can intervene with their biology or their psychology. So these are individual focused strategies. They typically involve changing beliefs, changing attitudes about drinking, changing normative perceptions, changing expectations for the outcome of drinking, specifically positive beliefs about what drinking is going to do for someone. and changing different behaviors, either changing behaviors around drinking or increasing protective behavioral strategies or other coping behaviors. Increasingly, there is a focus on how might medication be an adjunct to these preventive strategies, and some recent prevention approaches have combined medications that actually decrease the pleasurable effects of alcohol with more behavioral interventions to try to support young adults in particular in moderating their drinking. But again, as we think about the context in which that drinking is happening for different individuals, that drinking environment, we also want to focus on strategies that shift that context, that change those factors that promote alcohol use in that environment. So this can include the price of alcohol, especially if there's happy hour sales, things like that, that might entice people into drink, as well as how much taxation is on alcohol. So increasing taxes can decrease alcohol use. Considering the availability of alcohol, the density of alcohol outlets, especially in a particular area, the legality of alcohol use, so again, that minimum legal drinking age, as well as enforcement of the minimum legal drinking age. And then things like host and server accountability and liability. All of those are examples of environmental focused strategies. As we think about the drinking environment, we can somewhat break this down further to think about where we can intervene. So the Center for Disease Control and Prevention has the social ecological model in which they define 4 levels. So the individual is at the center in their drinking environment. That drinking environment is broken into relationships. So family, friends, peers, partners, people that are closest to the individual and might influence their drinking in one way or another. But those relationships and individuals are embedded within communities. So the direct context, this might involve the school or college, the workplace, and neighborhood. And of course, each of these individual communities are embedded within the larger societal fabric or the indirect context. So cultural norms for behavior, policies, and laws are examples of that societal level. And each of these point to different ways in which we might intervene to prevent alcohol use and associated harms. So this leads us to for whom and how should prevention be implemented? And it's important here first to talk about the prevention paradox. So the majority of the total alcohol-related harms are experienced by those drinking in lower or moderate risk ways. However, most people focus on heavier drinkers or higher risk drinkers because those individuals typically experience more alcohol-related harms individually. However, when you think about this as the total harms experienced, so for example, imagine each of these dots is an individual who consumes alcohol, and the number in the center of that dot is the total number of alcohol-related harms that individual experienced. You can see that there's far more people in the lower risk to moderate risk drinking area of this triangle and fewer in the higher risk drinking area of the triangle, and that those in the lower risk to moderate risk drinking area are experiencing fewer consequences individually than those who are drinking in higher risk ways. However, when you sum these, it becomes obvious that there's more actual consequences being experienced by lower to moderate risk drinkers. So for whom should we apply prevention? The answer is everyone. We need to apply prevention across the board, including those who aren't drinking. As I mentioned before, preventing initiation to drinking, as abstinence is the least harmful option, least risky option, is a goal. So we should be applying prevention to everyone. And there may need to be additional layers of prevention for those at higher risk. So as we think about that, these different levels of prevention, and this is the Institute of Medicine's Continuum of Care protractor. So health promotion is on the far left, but if we think about the wedge that's on prevention, we can think about universal strategies. These are strategies that are applied to everyone in the population. And then there's selective strategies. These are applied to individuals who are part of groups that research suggests are at higher risk of alcohol use or of experiencing consequences. In particular, we want to attend to groups at higher risk of experiencing disproportionate level of consequences despite maybe lower rates of alcohol use. And then the last wedge is indicated prevention. And these are strategies that are applied to individuals who are drinking in higher risk ways, who may or may not yet have experienced direct consequences associated with their alcohol use. Now, I think there's sort of a common misconception that individuals in this range probably are more appropriate for treatment, and some of them may be. However, specifically in young adults, there is this opportunity, especially as many of them do not see a need for treatment at that stage, an opportunity for indicated prevention to prevent further progression of higher risk drinking and actually promote a reduction in that higher risk drinking before long-term serious patterns and consequences develop. So thinking about those three levels of universal, selective, and indicated, a mix of strategies is ideal. Think about each of these gray dots as an individual who is consuming alcohol in a higher risk way within the broader population of individuals. If we apply a universal strategy, such as the minimum legal drinking age and enforcing that minimum legal drinking age, if we increase taxes on alcohol, and if we work to reduce alcohol density, that is going to affect everyone in the population, including those individuals drinking in higher risk ways. If we add in selective prevention approaches, such as personalized feedback or skills training to those groups at most risk for experiencing consequences, that's going to capture many, but not all, of those individuals drinking in higher risk ways. So we also need indicated prevention, such as a brief motivational intervention that is applied only to those individuals drinking in higher risk ways. Now, the key to indicated prevention, of course, is screening, because you have to first identify individuals that are drinking in higher risk ways before you can deliver a prevention strategy. And there's, of course, many different points where that screening might occur. It might occur within medical contexts, it might occur within the workplace, and it might occur within schools. One helpful way to think about the different steps necessary to implement effective prevention has been articulated by SAMSA. And so SAMSA breaks this down into 5 steps. It's a strategic prevention framework. And the first step is assessment. So determining local prevention needs and resources. And this goes back again to context, right? Drinking varies by context and it varies by individual and group. And so it's important to have a good handle on what are the specific prevention needs in your community in which you're trying to implement prevention, as well as what resources do you have to actually implement a prevention strategy. Thinking about this brings us to health and research-related disparities. So rates and patterns of alcohol use, as I mentioned, vary across groups, but the harms associated with use are disproportionately borne by certain groups. And in particular, again, sometimes with less alcohol use, right? Less alcohol use, but greater harm. And this is frequently experienced by members of marginalized groups. Past research on prevalence and harms, however, has taken a very categorical approach that focuses on a single dimension of identity. For example, looking at differences based on race and ethnicity, or looking at differences based on gender, as opposed to considering intersectionality and taking into account within group heterogeneity. So for example, when looking at categorical differences based on race and ethnicity, it may not take into account the high degree of heterogeneity within a particular ethnic category. For example, Latino, Latina, Latinx, there are a lot of different identities captured with that, where they may have different cultural influences. So there's sometimes misconceptions when we group different individuals together in these sort of artificial ways. Past research developing and testing prevention strategies has also utilized samples and contexts that are not typically reflected in most of the communities in which strategies are ultimately applied. That is to say, for example, within the young adult population, The samples and contexts in which the strategies have been developed and evaluated are typically predominantly white institutions or predominantly white universities, and the samples themselves are predominantly white, and then they are applied universally across different college contexts, for example, that may not be predominantly white, or different communities. A strategy that was developed in a college context is now applied in a community, and it may not work as well. So it's really important when you are doing your assessment and planning for which strategies you can pick, think about where the research has been done and how that fits or does not fit with the way in which you're going to be applying it in the communities in which you're going to be using it. So thinking about capacity, which is the second step in the framework, that's really about increasing capacity. So your assessment should have figured out what your baseline resources are, but now you want to increase capacity by building community resources and readiness to actually address the specific prevention needs you identified in your assessment. Key to this can be community coalitions. Community coalitions are diverse representative groups of stakeholders with a shared goal of alcohol prevention. They might include members such as representatives from government, law enforcement, health and social service agencies, nonprofits, foundations, associations, as well as school or college personnel. Really key often is businesses, especially those that sell alcohol. And especially, again, if you're trying to, say, implement prevention near a college campus, you want to include in your coalition those restaurant and bar owners who are closest to the campus. Other stakeholders might be the individuals who are going to be the receivers of the prevention services directly. So for example, in college students, if I was trying to implement prevention, we want college students to be members of the coalition. And of course, other invested community members. So there are some resources I'm going to point to if you're not sure how to form a community coalition that can help you to get started. The third step is planning, and this is really identifying available evidence-based prevention strategies and how you can implement those with your existing resources. And I bold evidence-based because that is really important. There are a lot of well-meaning, well-intended prevention strategies, often many of which look like they should work, but don't. So at best, they do nothing. And sometimes these very well-intentioned strategies actually increase alcohol use or other drug use. So it's really important to find evidence-based prevention strategies that you have a reasonable belief should reduce use and or associated harms. So the US Surgeon General has two reports on the website. One, Facing Addiction in America, the Surgeon General's report on alcohol, drugs, and health, which was published in 2016. The full report includes a number of repositories, some of which I'm going to list separately toward the end of my talk, that include a whole host of evidence-based prevention strategies that you can draw from. This particular report also includes information on how to form a community coalition. Additionally, the Surgeon General has their call to action to prevent and reduce underage drinking, which has useful information in intervening with those under the age of 21. One specific prevention strategy that's called out in the Surgeon General's report, as well as in a number of evidence-based strategy repositories, is the brief alcohol screening and intervention for college students, which again is my domain of research expertise. And most of my research has focused on this particular approach. Basics involves an individual who's trained in motivational interviewing to lead a conversation with an individual student about their drinking that's guided by personalized feedback. And that personalized feedback typically includes information that the individual has reported about their own drinking. So how much they're drinking, how many days a week they're drinking, as well as their perceptions of norms. How much do they think that their peers are drinking? How often do they think their peers are drinking? How acceptable do they think that their peers think drinking is? As well as their beliefs about alcohol and what it's going to do for them. So those positive outcome expectancies and negative consequences, or consequences that they've experienced, whether or not the student thinks that they're negative, along with protective behavioral strategies. So how do they mitigate the risk of harm? What are they doing to protect themselves when they go out and make the choice to drink? The personalized feedback can also include additional information such as risk based on family history for alcohol use problems, or other factors that may motivate young adults to make changes in their drinking, such as the number of calories in alcohol, the cost associated with alcohol, and similar factors. What basics shows and includes, and what makes it an effective strategies, includes many of the components that span effective prevention strategies. Really key, and if you take nothing else away from my talk, I hope you will hold that alcohol education alone is not an effective prevention strategy. It has been repeatedly shown that all education does is increase knowledge, and it does not translate into changes in alcohol use and other related behaviors. However, alcohol education is essential because it helps individuals to understand how to use skills that we might train them to do to, again, reduce their likelihood of harm. So you do need alcohol education, but you need that in the context of skills training. You can't just break alcohol education out from other effective components and expect for it to work. So the four components that are often present in effective prevention strategies, although not universally so, but they're often present, is alcohol education, some form of skills training, focus on increasing motivation, and building self-efficacy to actually use the skills that are presented. So one way of thinking about this is it isn't enough to know what to do and when and how to do it. You also have to want to do it, that motivational piece, and you have to believe that you're capable, that self-efficacy piece. And if you know what to do, when and how to do it, and you want to do it, and you believe that you can, chances are you're going to be more successful. So if we think about a specific example of these four components, the skill might be setting a drink limit to avoid a hangover, and a secondary skill of calculating BAC, or blood alcohol concentration. The alcohol education that might go along with this skill to support this skill use is BAC's effect on the body. That is, knowing at what BAC most people experience a hangover. The motivational piece comes in the person's belief that hangovers are undesirable. Again, if the person doesn't think a hangover is undesirable or actually thinks that a hangover is positive, then this is not going to be a good prevention target for that specific person. But if the person believes that they're undesirable, you help them develop the skill to set a limit to avoid it and provide them with the education necessary to do so. Then if you help focus on building the confidence in their ability to set that limit and to stick to it when challenges are encountered, chances are they're more likely to use that skill. The fourth step in SAMSA's framework is implementation, and this is actually going out and applying the strategies. You want to follow this up with the fifth and final step of evaluation. So assessing how well those specific strategies that were implemented changed the intended prevention targets. And then ideally sharing those outcomes out, again, so that other communities who are looking to implement the same or similar prevention strategies can learn how well it worked or didn't work and what worked or didn't work in your particular evaluation. Spanning all five of these steps is a central focus on cultural competence and sustainability, and with the notion there of working effectively across individual difference and focusing on implementing strategies that are going to have long-term impacts. Both of these point to the potential need for adaptation of evidence-based prevention strategies. As I mentioned before, many strategies are developed and first evaluated for efficacy in a particular context with a particular sample that may not match your context or the individuals that you are trying to implement prevention with. So the need for adaptation is really central, but then balancing fidelity to the original prevention strategy and how it was shown to be effective with adaptation becomes the challenge. One example of adapted intervention is the culturally adapted motivational interview, or CAMI, which was developed by Christina Lee and her colleagues. The CAMI was developed and evaluated among Latinx adults who identified as first or second generation immigrants. And the adaptations in this particular preventative intervention focused on social context and social risk factors for higher risk drinking. In particular, experiences of marginalization, discrimination, acculturation stress, isolation, and economic disadvantage. It also focused, though, on quality of social support and the relevance of social support to drinking, which may not be as big a focus if this same intervention was applied in a different group or in a different context. Additionally, a specific focus in the CAMI was the relation between changing family dynamics as a result of immigration and experiences of discrimination, acculturation stress, and drinking behavior, as well as refocusing discussion from the impact of drinking only on the individual to the impact of drinking on the family as a whole. Additionally, Lee and colleagues focused on embedding culturally relevant content into this adapted intervention, so including ethnic-specific drinking norms and risks for consequences. So at the bottom of the slide, you'll see one link to the most recent randomized controlled trial of the CAMI. And in addition, there's a second article by Craig Field and colleagues on the process for developing a culturally informed brief motivational intervention, which could be potentially applied, since the focus is on the process, to other groups. So as mentioned before, I want to leave you with some registries of evidence-based prevention strategies and programs. At the top is NIAAA's College Alcohol Intervention Matrix, or College AIM. Again, since my focus is on college students, this is a very pivotal registry for me. It includes both individual focused and environmental focused strategies. NIAAA also has the Alcohol Policy Information System. SAMSA has their own registry, the National Registry of Evidence-Based Programs and Practices, or NREP. The CDC also promotes a separate registry, which is the Community Preventative Services Task Force Guide. And finally, as mentioned in the Surgeon General's report, there's the Blueprints for Healthy Youth Development Registry, which is one of the ones, along with College AIM and the Surgeon General's report, that specifically named basics as a strategy. With that, I want to thank the Research Society on Alcoholism for giving me the opportunity to make this video. I want to direct you to their website for additional resources beyond those I've previously mentioned. And I want to thank and recognize the National Institute on Alcohol Abuse and Alcoholism, or NIAAA, for all the work they do to fund prevention research and to direct you to their website for additional resources. Thank you.